as you heard, I'm going to focus my talk on drugs that have been repurposed for COVID-19 and what we found thus far. I think that you've heard about a number of drugs already that have been repurposed for COVID, about some that have looked promising and some that have looked a lot less promising. And I think there's a lot to unpack here, but I'm going to do my best to share where things stand from a drug repurposing perspective. But I really wanted to start out by first just talking about repurposing generally and what I believe to be the promise of drug repurposing. So the concept of drug repurposing is taking a drug approved for one condition and then repurposing it to try it in another condition. And I'll share a personalized example of that. So just sharing a bit of background on myself, I first decided to go into medicine after my mom was diagnosed with brain cancer and unfortunately passed away about a year after her diagnosis. I knew I wanted to dedicate my life towards trying to find treatments for patients like my mom. Shortly thereafter, as a medical student, I was training with the goal of one day becoming an oncologist and helping patients like my mom. When out of nowhere, I became a critically ill patient experiencing multi-organ failure and being hospitalized in the exact same hospital that I'd been treating patients just weeks before. I was eventually diagnosed with a condition called idiopathic multicentric Castleman disease, which is a rare immune system disorder where your immune system attacks and shuts down your body's vital organs through a cytokine storm that occurs for an unknown cause. When I relapsed on the only drug in development, I decided that I would dedicate my life to trying to find a treatment for Castleman disease, began conducting laboratory research, and then realized I needed to really get involved in advocacy and connect with other patients, physicians, and researchers because I knew that I couldn't do it alone. I knew that I certainly wouldn't survive if I didn't identify a treatment that could maybe save my life. So I really, when I relapsed and nearly died for the fifth time, this is when I put the concept of repurposing into practice. I'd run out of all options, and really the only option for my survival would be to figure out what was going on in my samples and then to understand, are there drugs already out there, already FDA approved, that maybe could decrease the expression of something that I thought was too high or increase the expression of something that I thought was too low. So figure out what's going wrong and then see if there's a drug that's already approved that could fix that. So I ran a series of experiments, including serum proteomics, cytokine panels, and flow cytometry. When I integrated the data together using a number of pathway analyses tools like those listed on the screen, we identified a particular cell type, T cells, and also a particular communication line called the mTOR pathway that seemed to be activated. And before we considered what that meant therapeutically, I ran a really important experiment on my samples. And that's where I looked at normal lymph node tissue and then my lymph node tissue, and I stained them both for a marker of mTOR activation. And you can just see readily in front of you that that thing, the mTOR pathway, which is a critical component of the immune system, was highly activated in my samples, but not activated in the normal tissue. That led us to try an mTOR inhibitor called sirolimus, which was approved for kidney transplantation, and then began tracking it and giving it to other patients, which has led to a clinical trial that we have going on right now. Thanks to this drug, it's been 82.13 months since my last relapse. This drug, sirolimus, is literally saving my life. And you look at the previous lengths of remissions versus the current one. And here in the States, the New York Times called this "Doctor Cure Thyself," which I think is a bit of an overstatement, but I'm certainly thankful to be alive. And we've gone on to expand this work to other Castleman's patients, which we've published widely. So this is an example of what we call personalized medicine, where we figure out what's going on, we find a drug to fix it in one patient, then we expand it out to many more patients. So with that as a backdrop, I think you can imagine that when COVID-19 really began to hit the United States in early March, and we began to hear more and more about the cytokine storm occurring in COVID, and started to get data back on the particular proteins and these cytokines in the blood that were elevated, the immune hyperactivation. It became quite clear that there were a lot of similarities between what I had experienced as an idiopathic multicentric Castleman disease patient and certainly other COVID patients, and also a lot of similarities between the approach that we took to identify repurposed drugs and sirolimus is just one of multiple drugs that we've discovered in my lab and through our center that are effective, or that we believe to be effective, for cytokine storm disorders. So we decided that we would throw our hat in the ring and get involved. Here I'm trying to show you that on the left is a photograph of an idiopathic multicentric Castleman disease patient in the ICU with multi-organ failure due to IMCD. And on the right, it's a COVID patient with the exact same multi-organ failure, almost identical clinical and laboratory abnormalities, but in this case, it's due to SARS-CoV-2 infection. So earlier you heard a little bit about a drug called Tocilizumab that many of us were really optimistic could be effective for severe COVID-19 patients. Tocilizumab blocks the interleukin-6 receptor. The photograph on the left of the screen is of a good friend and colleague of mine, Kazu Yoshizaki. Kazu first discovered that interleukin-6 is elevated in Castleman disease. He developed a drug called Tocilizumab that blocks the IL-6 receptor. And he developed that drug for Castleman disease patients in Japan. And I had heard from a colleague of his that he had given the drug to himself before he gave it to other humans. This is in the mid to late 90s, before monoclonal antibodies were frequently administered to humans. And when I asked Kazu about it, I said, Kazu, I heard that you gave yourself Tocilizumab as the first human to receive it. He said, no, I didn't give it to myself. The nurse, she gave it to me. So Kazu Yoshizaki discovered the drug target, developed the drug. He actually gave it to himself, which of course we're having an ethical discussion today, and whether or not that's ethical or right is certainly something we can discuss extensively today. But then he didn't die when he gave it to himself. Went on to give it to other humans through a phase 1 trial, and it went on to get approval in Japan for Castleman disease. It went on to get approval for other conditions as well. You guys may be familiar with how Tocilizumab is used in cytokine release syndrome that occurs following a certain type of cancer immunotherapy. And then, as I mentioned, there was a lot of hope, and maybe you could call it hype, that Tocilizumab was going to be effective in SARS-CoV-2 patients. But as we've seen, additional headlines have come out, and additional phase 3 studies have come out suggesting that this drug does not work in COVID, at least not in the groups that were studied in these large phase 2 trials. But I think it's important to consider how drugs can be developed for one thing, in this case, developed for Castleman disease, repurposed for cancer immunotherapy, repurposed for rheumatoid arthritis, and then tried to be repurposed for COVID, but doesn't seem to show a benefit. So with this backdrop, back in early March, my center, the Center for Cytokine Storm Treatment and Laboratory, we decided to launch a project called the Corona Project, which would keep track of all drugs being given to COVID-19 patients worldwide, reported to be given to COVID-19 patients worldwide. Early on, we expected there to be maybe a couple dozen drugs that were given, but we've really been completely blown away by the large number of treatments administered to COVID-19 patients thus far. So anyone can access the data, and you can play with the data and interact with it at cdcn.org/corona. There's a screenshot on the left of the screen to see it, but the bottom line is that we've gone through with this army of volunteers data from over 100,000 reported COVID-19 patients, and over 300 drugs have been given to this group of the first 100,000 patients that we've studied. So doctors are trying all kinds of things on patients. And I should mention the majority of these patients are outside of clinical trials. So there's a tremendous amount of off-label drug repurposing that's happening. And then, of course, there's also a lot of drugs being tried through clinical trials. But there's a tremendous amount of drugs just being given to patients, and as we heard earlier, without clear evidence that they are going to be beneficial or not. So we made this data openly available. I really hope you all feel free to play with the data. We shared the data directly with the FDA here and with a number of collaborators, including Google Health and HHS, who are using this information to help to guide and prioritize drugs that should move forward to randomized controlled trials. The idea is that all of this information on what drugs are being used anecdotally, whether they look effective or not, this needs to be used to then inform which drug should move forward to a randomized controlled trial, because you really cannot make calls on effectiveness of drugs without a randomized controlled trial. We also, in parallel to this, our center, we all call it the Castle. We're also searching for additional therapeutic targets and have found a few that we've reported. So a couple insights that came from the first 9,000 patients. We published this quite early on in the pandemic, but it was basically just a snapshot of what drugs have been used to date in the first 9,000 reported cases. What are some of the classes of drugs that have been used? You'll notice that hydroxychloroquine was, I think, about number 15 on the list of most frequently used drugs at this stage. As you probably saw on the screen before, it is by far the most frequently used drug, at least individual drug. There's about almost 40% more uses of hydroxychloroquine than the next specific drug, which is lopinavir or ritonavir. So it's been just used prolifically. But that's one observation, is that hydroxychloroquine is used prolifically, despite randomized controlled trial data that suggests that it is not effective in various populations of COVID patients. But another takeaway that was really surprising to us was that corticosteroids were the number 3 drug class being used despite international recommendations. You may remember that in the first 3 months of the pandemic, WHO, US CDC, a number of regulatory bodies, they didn't recommend what you should give patients, but they very strongly recommended not to use corticosteroids. They didn't tell you what to use, but they said, don't use corticosteroids, despite the fact that it was the only thing that anyone recommended against. It was still being used very frequently. You can see in the first 9,000 patients, a quarter of these hospitalized patients got corticosteroids. And so we were very confused about this and didn't really know what to make of it, but that continued on and on and on. Doctors continued to prescribe corticosteroids despite international recommendations against using them. Another interesting finding was the prolific use of interferon alpha and interferon beta. Interferon alpha and interferon beta, these are 2 cytokines. They're called type 1 interferons that actually stimulate an immune response. And so what was surprising is that they were being used extensively outside the US, but really were not being used at all within the US. We think in part due to the fact that it's counterintuitive when you think about a cytokine storm disorder to say, I'm going to give a cytokine to patients that have too many cytokines. And I think that conceptually it doesn't make sense, but as you think about it further, actually, and as we've learned more and more about interferon, in particular, some genetic mutations in interferon and also autoantibodies against interferon, it's become more clear that actually stimulating the immune response with interferon early may actually be helpful versus suppressing it late may be helpful. And so, as I mentioned, anecdotally, there were reports that doctors, at least in the US, were concerned that giving interferon would actually worsen the cytokine storm. And we do now know from the UK that if you give interferon to late stage COVID patients, it looks like there is a trend towards a worsening outcome. But some work from our lab has revealed that that there are a number of pathways that seem to be not yet activated enough in early COVID and too activated and too strongly activated in late COVID. And so it's kind of thinking about this disease, in my opinion, as more of a balancing act as opposed to being a cytokine storm disorder where it's just too strong or an immunosuppressive state where it's too weak. I think it's really about this balancing act of the immune response. So this is kind of my attempt to visualize the balancing act, where on one side of this, you can have too weak of an immune response, which occurs often early stage in infection. You can also have too strong of an immune response, which typically occurs late stage in COVID. Drugs like dexamethasone have been shown very clearly in multiple randomized controlled trials that they improve mortality in patients experiencing this too strong or hyperinflammatory response, certainly patients that have high C-reactive protein levels and late in disease course. But if you give patients dexamethasone that don't yet have oxygen requirements, that don't yet have an elevated CRP, you actually can worsen their immune response. Dexamethasone is an immunosuppressant, so it's going to move you from the right side of the spectrum to the left. It's going to move you from too strong to too weak. But if you have the right immune response and you take dexamethasone, you're going to move towards too weak an immune response. And if you're too weak, you're going to be even weaker. So this is an example where you need to give dexamethasone at the right time, which is in the hyperinflammatory patients. I mentioned interferon beta, which it looks like if you give it early on in the course of disease, and certainly particularly in patients with interferon dysfunction, then it likely will get you to that modulated point of an optimal immune response. There is not an RCT out yet. There's a press release about this, but I haven't seen the data suggesting that this is the case. But again, you would you would assume that if you give interferon beta when you're having a modulated immune response, that you could actually make things worse. And certainly if you have a hyper response, you really don't want to give interferon because that could stimulate it in bad ways. So thinking about all the data we have and how we try to kind of piece this together, when you think about SARS-CoV-2, there's obviously the virus, which can lead to symptoms on its own, just purely from viral infection. And then there's the immune response, which is attempting to control the virus with antibodies and also with cytokines. That immune response, the same antibodies and the same cytokines from the immune response that are trying to control the virus can actually also lead to symptoms and damage to the host, which we consider to be typically inflammatory symptoms. And so here again, we have this spectrum where you want to be kind of in the middle. You don't want to have symptoms that are caused by the virus. You don't want to have symptoms caused by the immune response. And one way to prevent immune response symptoms is through immunosuppressants, to weaken that immune response. That'll move you more towards the left. You can also use immune stimulants to boost up the immune response against the virus, which will move you more towards the right, where if the virus is causing problems, you want to get more towards the middle. You can also use neutralizing antibodies like these neutralizing antibody monoclonals that you can that Regeneron and Eli Lilly have developed. You can also use convalescent plasma, and then lastly, you can think about antivirals that directly focus on the viral infection. To date, we've been really trying our best to keep track of all the different drugs that fall into these various categories, which ones met their primary endpoint by an randomized controlled trial, which ones failed to meet a primary endpoint. And you can see on the screen here a number of drugs early on that were identified that maybe would be considered to be antivirals, and even heparin, which many of us would not think of as antiviral, is thought to have antiviral activity. You can see here that some of them have failed to meet primary endpoints, and others have met their primary endpoint in randomized controlled trials. And then the same really for immunosuppressants. And as you can see, Tocilizumab and Perelman, those are IL-6 receptor blockers, those are crossed out. Another way to visualize this is that you can think about timing of treatment and severity in this kind of 2x2 axis, where dexamethasone works for people late stage, very severe, whereas remdesivir and interferon beta, based on surrogate endpoints, seem to be more effective if they're early stage and less severe. A drug like baricitinib is another immunosuppressant that seems to kind of fall in the middle, but doesn't yet have clear data. So this is my last couple slides are really just around thinking about drug repurposing generally and a framework for drug repurposing. So the first concept is that there's about 2,500 drugs approved by the FDA here in the United States. Those 2,500 drugs are approved for about 3,000 diseases. Yet there are about 7,000 more diseases that don't have any approved drugs. And so drug repurposing is really around the concept of saying, of these drugs that are approved, can those help either drugs that already have diseases that already have approved drugs, or particularly those diseases that don't have any approved drugs? Now, there are at all times drugs in development that are going to increase that number to 2,500 and hopefully knock out a few of these diseases that don't have any options. But the reality is that that approach is going to take decades, centuries, frankly, to address the 7,000 diseases without approved drugs. But there actually are many drugs that do have an established effect in playing a role with a disease that doesn't have an approved drug. There are also drugs that have a known possible effect that need to be studied further. And finally, there are drugs that exist that have an unknown possible effect, like the drug sirolimus that we repurposed to save my life. No one knew that it would be effective until we did the research to find out that we thought it could have an effect, and we started using it. So one way I think about drug repurposing is around first identifying and validating candidates that might be effective, then using real-world evidence to get a sense for whether they seem to be effective in the real world, and then turning towards interventional studies to get a sense for whether they actually are effective. Of course, there's a little bit of back and forth here, but at the end, we're trying to get towards clinical use where it either is FDA approved or it's simply adopted in clinical practice. And of course, if it's not effective, you want it to not be used in clinical practice. So this is where our Corona project really is focused. We also are in the process of trying to expand our Corona project to integrate preclinical data along with now the human clinical data. So moving forward, future directions, we're going to continue to track drug repurposing in Corona and also identify promising drugs for clinical trials in partnership with the FDA, as I mentioned earlier. We also plan and hope to be able to integrate and expand Corona to include the preclinical drug repurposing data. As you probably know, there are press releases and papers published every day about a new drug that's effective in a new cell line or a new hamster model or ferret model of COVID. And how to keep track of all these things and have them in one central place is something that we're working on. We'll continue to investigate the inflammatory response in COVID and search for actionable drug targets. And lastly, we'll continue to advocate for drug repurposing beyond COVID. On the right of the screen, we have a picture of a cartoon. It's a cartoon of an old dog reading a book about new tricks. Here in the States, we talk about you can't teach an old dog new tricks, but I think what we're trying to do is to take old drugs and teach them or find new ways they could be used. So really trying to teach old drugs new tricks. And of course, I just want to thank my really wonderful team, both in the Center for Cytokine Storm Treatment and Laboratory and also the Castleman Disease Collaborative Network, who focus most of their time on Castleman's, but also a good bit of time on the cytokine storm disorders like COVID-19. And as was mentioned in the beginning, I had the opportunity to share this experience and my story through a book I wrote that came out last fall called Chasing My Cure, and just felt like I needed to share this journey with the world. And hopefully you guys will check it out, and please feel free to reach out to me at the email on the screen with any questions.